أهلا بكم. Today we're going to continue with our face, parotid, and suboccipital triangle lectures. Today is the face. So let's start. Um, uh, the bony face, the bones that contribute to the formation of the face. You can see here like the frontal bone, the zygomatic bone, the maxillae, both maxillae, and the two nasal bones, and the mandible. You can see the articulation, the sutures between the bones we just mentioned, the frontal and the zygomatic and the nasal bones and maxillae and the mandible. Appreciate the contributions to the cavities, like what bones contribute to the orbital cavity, for example. You can see here the greater wing of the sphenoid, and this is the lesser wing of sphenoid. Okay, you can see the maxilla are contributing to the orbit, the zygomatic bone contributing to the orbit, as well as the frontal to the orbit. And also note that the nasal cavity actually is in between the orbital cavities. The medial wall of the orbit is the lateral wall of the nose. Don't forget that, please, and don't forget this relation. It's not completely below the orbital cavities, the nose. And also notice that the floor of the nose is the roof of the oral cavity, which is the hard palate, as you can see here. Observe the foramina. This is the supraorbital foramen, here, this one. This is the infraorbital foramen. This is the mental foramen. Observe that they are all on one line. See? On one line. The mental, the infraorbital, the supraorbital. These are called the supraorbital ridges, the upper margins of the orbital cavity. Okay, notice also that the face is hanging down below the level of the base of the skull, and you can see that here. See? The face is hanging down below the level of the base of the skull to give space for the inverted mask, the one we talked about, the pharynx, exactly, to give space for the pharynx to connect to the back surface, back aspect of the nose and oral cavity all together. Okay, so remember this, it's at a lower level. I observe the processes of the zygomatic bone here. It has a temporal process for the temporal bone. It has a frontal process for the frontal bone. It has a maxillary process with the maxilla. Observe that. Also observe the temporal fossa on the side of the skull. Of course, we will be talking about the face today, the front aspect. Okay? Now, the muscles of the face are common in that they are derived from the second branchial arch, or the second pharyngeal arch, which takes its nerve supply by the facial nerve. So they are called muscles of branchiomeric origin. Even the fibers supplying, they are classified into branchiomeric efferent or special visceral efferent fibers. The special or branchiomeric means it goes to muscles that derive from the pharyngeal arches. Also, these muscles have in common that they are all in the superficial fascia. They are all insert in skin, but they don't all originate from bone or tissues. There are some muscles, like the risorius, for example. It has no bony attachment. It's from skin to skin. You will see that. The function of these muscles, they are facial expression muscles. They control the orifices of the body, control the orbit, control the nose, control the mouth opening. And a better way to study them, of course, doctors, we are not going to study individual muscles of the face. We'll pick up a few muscles. There are a good number of muscles. which are unique in something, and they are the muscles of the face that show up in MCQ multiple choice exams. Other than that, I never encountered questions about the other muscles other than the one we were going to stress on today. So a better way to study the facial muscles, to divide them, classify them into groups: orbital group, nasal group, oral group, and other muscles that don't belong to these groups. The orbital group, let's take, of course, the orbicularis oculi and the corrugator supercilii. So the corrugator muscle is in the middle, but the important one is the orbicularis oculi muscle. See, it's classified in another classification according to shape into muscle that has circular fibers. It's of the circular type. As you can see here, the orbicularis oculi, it's big. It covers area around the orbit and goes through the upper and lower eyelids as well. See that? So this part is called the palpebral part in the eyelids, in the upper and lower eyelids, and this part is the orbital part, which is around the orbit. Now notice that the origin of the palpebral part is from a band of connective tissue here, a ligament. It's called the median palpebral ligament. It goes in circular fashion in the upper eyelid, then inserts in another ligament here, the lateral palpebral ligament, but few fibers fuse with the inferior part of the palpebral, the one in the inferior eyelid. Okay, back to the median palpebral ligament again. But the orbital part, it takes, yes, from the medial palpebral ligament, but it does not insert into the lateral. Actually, it's a continuous part. Why? To get the purse string action of this muscle. Actually, the palpebral part, we use it for blinking, and the orbital part, we use it for tight closure of the eye in case there is a sandstorm or something, for eye protection. So remember this, that the orbital part of the orbicularis oculi muscle does not insert laterally in the lateral ligament, rather than that it's continuous as circular around the orbit. Now there is another hidden part, small part. It's called the lacrimal part. It's behind the lacrimal sac. Be careful, not the lacrimal gland that's up and lateral here. It's behind the lacrimal sac. The sac drains the tears from the lake of tears formed here in the lower eyelid by a couple of puncti that leads to a couple of canaliculi to the sac. Now the muscle fibers attaches to the sac. When the muscle fibers contract, they pull on the sac as if to dilate it, as a suction mechanism of tears from the lake of tears in the inferior eyelid, to increase the suction of tears inside the sac and eventually down to the nose through the nasolacrimal duct. Do you remember where did it open? Yes, the inferior meatus of the nose. So remember, the orbicularis oculi muscle has the orbital part and has the palpebral part and has also the lacrimal, tiny lacrimal part. Okay. Nasal group. Nasal group, you can divide them into nasalis muscle, procerus, depressor, septi. No, don't stress on these muscles. And it has other muscles that are related to the nose and the superior lip, like the levator labii superioris, alechnizai, for example. You don't have, I mean, my strategy is to pass exams. You don't have to study these, to stress on these to pass exams. We will pick some some muscles, okay? But remember that nasalis is the largest. It has a compressor part and a dilator part. Compressor, of course, up here, dilator at the ala, the nasalis muscle. The oral group, you can classify the muscles of the oral group into orbicularis oris, buccinator, and upper and lower groups. Orbicularis oris, buccinator, and upper and lower groups. The orbicularis oris muscle, like the oculi, it encircles the mouth. Actually, there is a visible part which is in the lip. These muscle fibers, these fleshy fibers of the lip, are the fibers of the orbicularis orbicularis oris muscle, and as you can see, it interdigitates with all the surrounding muscles. Okay, to form a continuous mass even, but with different directions. The buccinator, we all know about the buccinator now, that arose from the pterygomandibular raphe. Remember that? The common origin for superior constrictor and the buccinator anteriorly. And we said that it goes lateral to the teeth, grooving the mandible as it emerges laterally, and goes anteriorly to insert itself in this. See this node here? This is called the modulus. It's a piece of connective tissue and muscle fibers connecting many muscles that insert into it. So buccinator inserts into the modulus. Remember, the buccinator is pierced opposite the upper third molar, and the duct of the parotid stays for a while there, and then opens opposite the upper second molar in the vestibule of mouth. Okay. About the upper and lower groups. Lower groups is mentalis, for example. Mentalis and depressor anguli oris muscle. You don't need to stress on these. Upper group, I will pick the rhizorius and zygomaticus major and minor. This is the rhizorius muscle, and this is the zygomaticus major. There should be a minor besides it. Why did I pick these up? The facial artery, when it enters the face, it's superficial to all muscles except the platysma, rhizorius, and the zygomaticus major and minor. The facial artery is deep to these muscles. Okay? Deep to these muscles. Deep to the zygomaticus major and minor, deep to the rhizorius, and deep to platysma. Remember this, please. And this came as a multiple choice question. So these three muscles I would pick up for sure. Okay? Another thing unique about the rhizorius, that the rhizorius does not originate from bone. It's from skin to skin. It has no bony attachment at all, from hypodermis of skin to hypodermis of skin. Okay? So don't forget these two pieces of information about the facial artery deep to these muscles, and about the rhizorius being from skin to skin. Okay. Other muscles, like the platysma, for example. See, this is the platysma. It comes from the pectoral region. It doesn't have to come from the pectoral region. It varies among individuals, sometimes from the middle of the neck high up to inferior border of mandible, or even the muscle fibers can go higher up and attach to the lower lip. Okay, so it varies between individuals. It's in lower animals like horses, for example. The platysma covers the whole body. The horse can tremor any part of his shake any part of his skin with the continuous platysma to push off flies away. Okay, of course we don't need that. That's why it's rudimentary in man, the platysma muscle. Why was it classified as muscle of facial expression? Because supplied by the same nerve, the facial nerve. Okay, we have auricular muscles, by the way. Anterior auricularis, superior auricularis, posterior auricularis, and they are all rudimentary and vary from individual to another. I even read about ear muscles inside the cartilage that connect the cartilages together. They classified these muscles as intrinsic muscles of the ear, and the auricularis are the extrinsic muscles. Well, it's weird, but it looks like there are some muscle fibers between the cartilages inside the ear pinna as well. So these are called the auricular muscles, also supplied by the facial nerve. The occipitofrontalis muscle. It's two muscle sheets on the skull. One at front, the frontalis muscle. One in the back, the occipitalis part, which is smaller than the frontal part. And they are connected by aponeurosis, broad aponeurosis, tough aponeurosis, called the galea aponeurotica. Galea aponeurotica, the aponeurosis that connects these two muscles as well. Well, you may ask why the occipital is considered muscles of the face. It's at the back of the head. Well, because it's supplied by the same nerve, the facial nerve. So it's considered muscle of facial expression. Okay? So these are other muscle types like the platysma, auricular muscles, the occipitofrontalis. Don't forget these muscles and stress on these other than stressing on the rest of the muscles of the face. You'll be wasting your time. Okay, innervation of the face. Doctors, there are numerous branches. Okay, I'll mention these branches just to point them out, but I prefer, it's better to understand the innervation of the face when we study individual branches. We studied some so far, and we will continue with the rest, and by time you will be able to construct the map of the nerve supply of the face by yourself. But let's see. It's shared by ophthalmic. Ophthalmic takes the top of the nose, the upper eyelid, and goes upwards and backwards till the vertex. Vertex is the highest point on the skull. The ophthalmic. Then the maxillary takes the lower eyelid and the cheek area, the maxillary nerve. And the mandibular nerve takes the temporal side. We will study this with the temporal fossa, but it's branches. Some of the branches are continuous, as you can see here. This is the inferior alveolar nerve, branch of mandibular that came out from the mental foramen and became mental nerve. Okay, so ophthalmic, maxillary, and mandibular share it. Ophthalmic, like for example the supraorbital nerves, see, they're usually double. See how far they go back to the vertex. And supra and infratrochlear nerves, these two tiny nerves, you see them? This one and this one. One above the trochlea of the superior oblique, one below the trochlea of the superior oblique, and we will study this. Now, this from ophthalmic. From the zygomatic, you can see the infraorbital branch. Sorry, from the maxillary, you can see the infraorbital branch. You can see it here, supplying the nose and the upper eyelid and the cheek area. And the zygomaticofacial nerve, this one, another zygomaticotemporal nerve at the back. This all supplies the face. The buccinator nerve, the one that goes to the buccinator but not to motor supply. It's a sensory nerve that's sensations, proprioception from the muscle, as well as sensation from the overlying buccal pad of fat till skin, and the adjacent gingiva as well, the buccal nerve. Okay. What else? We said this, the mental branches here of the mandibular. Of the mandibular too is the auriculotemporal nerve that's supplying the skin over the temporal area. Okay, so you can say a lot about the nerve supply of the face because it's numerous. It comes from, but it's all from the trigeminal, except the skin over the parotid and the angle of mandible, which is supplied by, well, can you remember this? Skin over parotid and angle of mandible supplied by C2 of great auricular nerve from the cervical plexus. So please do not test for the mandibular nerve function by touching the patient here in this area. No, go anteriorly and at the chin area where you can feel or test the mental branches of the inferior alveolar of the mandibular. Okay, this is the tricky part about the innervation of the face. Okay, what else? Motor supply of the muscles of the face. We said the dominant nerve, of course, is the facial nerve. The facial nerve has a long story inside the cranial cavity. It arises from its pontine nuclei and goes into the internal acoustic meatus as two nerves, actually, the facial nerve proper and the nervous intermedius part. The nervous intermedius part will be responsible for the parasympathetic supply and conveys the sensation of taste, the nervous intermedius. Anyway, we will get to the story eventually, but after inside the ear supplying the stapedius muscle and forming the geniculate ganglion and giving off the chorda tympani, which will carry taste from the anterior two-thirds of tongue, it emerges out, as you can see here, from the stylomastoid foramen. So it comes out through the stylomastoid. This is the styloid process. This is the mastoid process. There's a foramen between them at the base of skull that it gives rise to the facial nerve coming out of it. When the facial nerve descends, it gives off a posterior auricular branch to supply the posterior muscles of the ear, not the temporalis, please. Posterior muscles of the ear and the occipitalis part of the occipitofrontalis. It gives off two branches to stylohyoid and posterior billy of digastric, then enters the parotid. So the branches we've mentioned, the posterior auricular, stylohyoid, and posterior billy of digastric, before it enters the gland. Now it enters the parotid gland. And inside the parotid gland, the pattern of division will vary between individuals, but eventually it will give a temporal branch, see, zygomatic branch, and buccal branch, marginal mandibular branch, and cervical branch. This is very important. Temporal, zygomatic, buccal, marginal mandibular, and cervical. They divide the gland, as we said, into superficial and deep parts surgically. Okay? Now you can see it's for the muscles of the face. The buccal branch here is the motor supply for the buccinator muscle, and the cervical branch here is the motor supply for the platysma. It's supplied specifically by the cervical branch, and we mentioned the cervical branch before in the submandibular region when I told you that it's superficial here in the submandibular region. So if you're going to make an incision, make it lower down, not near the margin of the mandible, so as not to cut these nerves. Okay. This is the story of the facial nerve, but we will get back to the intracranial part later. Okay, arterial supply of the face, of course, numerous sources as well. From the ophthalmic artery, you get the supraorbital, supra, and the infratrochlear branches, the same as the nerve, but differs than the nerve is that it has a lacrimal branch that gives off the zygomaticofacial and zygomaticotemporal. Okay, remember the zygomaticofacial and temporal nerves are from maxillary nerve, but here the zygomaticofacial and temporal arteries are from the ophthalmic through the lacrimal part of the ophthalmic. Okay, this is the blood supply or the ophthalmic share. The of course, the major artery is the facial artery. It arises from the external carotid. Remember, the first one was superior thyroid, then lingual, then facial. Opposite the origin of the occipital from the backside of the external carotid. The facial artery has a tortuous course. It ascends, uh, uh, goes to the posterior aspect of the submandibular gland. Of course, it's hidden here. Then superior to it, then lateral to emerge on the face, crossing the inferior margin of the mandible. See? So why did it go inside first at the region of the submandibular gland? Because it will be right next to the pharynx, or the oropharynx to be precise. It will give there the ascending palatine artery, remember that, for the supply of the pharynx, and the tonsillar branches to the palatine tonsils. Remember the supply of the palatine tonsils from the facial. The facial also, when it's near the on the submandibular gland, it supplies the gland, gives glandular branches to supply. So lots of branches here before it emerges on the face. Now please, it emerges on the face, on the mandible, anterior to the masseter muscle, anterior to the facial vein. These are questions I encountered. Anterior to masseter muscle, anterior to the facial vein, okay, which is on the muscle. The facial vein is not anterior to the muscle, and with gentle pressure with your index finger, you can put your finger here and clench your teeth and put your finger in front of the masseter against the mandible, and you will feel the pulsations of the facial artery. Okay, now the facial artery continues its journey, giving inferior labial, superior labial, nasal branches, and ends by becoming the angular artery or the medial canthal artery that anastomoses with the supra and the infratrochlears here. Okay, this is the facial artery. Of course, it supplies all the muscles it passes over. Remember, I told you the facial artery is superficial to all the muscles except it's deep to the the platysma covers part of it, the rhizorius, zygomaticus major and minor. It's deep to these muscles. Do not forget this. Okay, these are the branches of the facial artery. Of course, as we studied, I think they're easy. There's no problem about that. Another source for the supply of the face is the transverse facial artery. See that? This is the transverse facial artery. Transverse facial artery from the superficial temporal artery, and it goes anterior above the duct of the gland and below the zygomatic arch, between the two, between the duct of the parotid gland and the zygomatic arch, the transverse facial vessels, actually, the artery with the vein. It shares in the supply of the face, of course. Okay, what else? Emerging from the infraorbital foramen, the infraorbital artery, which is a branch of the maxillary artery. Emerging from the mental foramen, mental artery, branch of the inferior alveolar artery, which is a branch of the maxillary artery. Okay, so don't confuse the names of the arterial branches with the nerves. The sources are different. Okay, this is the arterial supply of the of the face. And by time, we will study, I think, especially when we get to the orbit, we will study individual branches. The maxillary artery branches are, so as we said, the infraorbital and the buccal artery that goes to the buccinator muscle, and we said the mental artery, which is from the inferior alveolar, and we mentioned the ophthalmic artery branches, supratrochlear, supraorbitals, and infratrochlear. Now, remember that these high upper branches are coming from the internal carotid artery, while those arteries are coming from the external carotid artery. So the internal and external carotid share in the supply of the face. Okay, this is the ophthalmic artery. Gives, we said, zygomaticofacial temporal, supraorbital, supratrochlear, ends by becoming dorsal nasal or external nasal. The branches of ophthalmic artery. The venous drainage to the facial vein. The facial vein is formed by anastomosis of the supra or union of the supraorbital and supratrochlear nerves, veins. They form the angular vein that becomes the facial vein and takes the tributaries as far as it descends. It accompanies the artery posterior to the artery till the moment that till the inferior mandible, inferior margin of the mandible, it leaves the artery, doesn't go deep with it in the submandibular region. It becomes superficial in the submandibular region and joins the anterior division of the retromandibular vein. See that? This is the retromandibular vein that replaces, there is no external carotid vein, but there is a retromandibular vein that divides into anterior and posterior branches. The anterior branch with the facial make the common facial to the internal jugular vein. Okay. There's also a transverse facial vein that accompanies the artery that drains into superficial temporal vein. And the most important thing to be mentioned about the venous drainage of the face, that there are connections with the cavernous sinus. Again, the cavernous sinus at the size of the pituitary gland. Because infection, if reached the cavernous sinus, it's a catastrophe. Actually, it's an ugly illness. Okay, say the sites for the connection through the infraorbital branches, so through the medial canthal branches, medial corner of the eye branches, the facial vein itself connects to the pterygoid venous plexus, and the pterygoid venous plexus connects to the cavernous sinus as well, to inside the cranial cavity. So there are connections, and they classified this area of the face above the upper lip that includes the area of the infraorbital and the supratrochlear and supraorbital as the dangerous area of the face. Dangerous area of the face because the veins of the face are valveless. The blood moves in both directions. Okay, so any infection, if applied force to it, for example, it will squeeze itself in tiny capillaries and such, and maybe drained inside and cultivates inside the organism, I mean. So the infection from the upper part of the face, which is called the dangerous area of the face, will it may, I mean, go to the cavernous sinus by these connections. Okay, the lymphatics, submental, submandibular glands, preauricular parotid glands, okay, lymph nodes, I mean, and eventually from this superficial circle to the deep cervical lymph nodes. This is about the blood and venous drainage. Now, there are a couple of cases, clinical cases, about the facial nerve. The facial nerve nuclei are divided into an upper part and lower part, each for the ipsilateral half of the face. I mean, the right nucleus has upper part for the ipsilateral upper part of the right half of the face, for example, means the upper quadrant, and the lower quadrant, lower nucleus for the lower quadrant or ipsilateral side of the face. Ipsilateral means at the same direction, contralateral at the opposite direction. Now, what's unique about these, of course, you will study in neuroanatomy that the cranial nerve nuclei and the spinal cord nuclei, they receive corticobulbar and pyramidal tracts, for example. The control from the higher centers, from the cortex to the cranial nerve nuclei is called corticobulbar. The upper part of the facial nerve has a double supply from its cortex and the contralateral cortex, but the lower one is only from the contralateral cortex. This doesn't have a dual supply like the upper part. So as if the upper part of the face is protected, has more protection against injuries or paralysis, for example. That's why the lesions of the facial nerve differ. The lesions of the facial nerve. Sorry about that. I didn't notice that the slide flipped. The lesions, they differ from region to region, from site to site. For example, if there are central lesions means from the centers down to the facial nuclei, so above the level of facial nuclei. Let's say another lesion at or around the geniculate ganglion, the one that the facial nerve forms in the middle ear. We will get to these details in the ear. Don't worry about that. Or lesion around the stylomastoid foramen where it emerges. Now, above the facial nucleus, we said there should be ipsilateral paralysis of the face, but the upper half of this part will be protected because it takes from dual nerve supply from the cortex. So you will be left off, the patient will be left up with the lower quarter of the same side of the lesion. Okay? If around the geniculate ganglion, now this is a different story because the lesion is before the facial gives origin to the great petrosal nerve, for example, that carries parasympathetic and taste to the glands above the oral fissure, or the chorda tympani, which carries parasympathetic to the submandibular, sublingual, and the taste from anterior 2/3 of tongue. So all this will be lost. So there will be loss of lacrimation, loss of salivation at the side of lesion. See, there's a difference now. Above the nucleus, it was only motor, but now it's motor, taste, and loss of parasympathetic. Now, at the stylomastoid foramen, the nerve would be already given its branches, so everything will be spared except for the motor function of the muscles supplied. So there will be ipsilateral hemiface paralysis. Okay, now the facial, the one with Bell's palsy, the face will be pulled to the healthy side, and the flat side is the paralyzed side. Can't close his eyes properly. The eye will be always open, so lots of tears accumulating in the eyes. He can't activate the buccinator, so he cannot whistle. He cannot, the food always dripples and saliva always dripples at the side of the paralyzed, because we said that the buccinator pushes the food inside against the alveolar, against the teeth. Okay? Another clinical case for the trigeminal ganglia, it's called the tic douloureux, in French, trigeminal neuralgia. It's idiopathic. Idiopathic means the cause is unknown for unknown reason. Idiopathic involvement, neurologic state of the trigeminal ganglia in which there is severe pain along the areas drained or supplied by this nerve, except especially the maxillary and mandibular. I heard that one of the old treatments was to go inside and inject that gland with alcohol to stop the conduction of pain from the face. The last subject will be the scalp. The scalp is a series of layers, starting with the skin, then a dense layer of connective tissue, and a layer of aponeurosis, then a loose connective tissue, and then the periosteum or the epicranium of the skull. The initials make the word scalp. C, skin, connective tissue. A, aponeurosis. L, loose connective tissue. And P, pericranium. It's easy to remember the layers. The first three layers are fused together, means the skin and the dense connective tissue and the aponeurosis are fused together as one piece. They move together. The skin is unique, of course, with the large amount of hair follicles. The dense connective tissue layer beneath the skin actually carries also the vasculature and nerve supply of the area. This means that injury that involves this layer, the hemorrhage will be profuse. Why? Profuse is too much, I mean. Why? Because the dense connective tissue pulls on the walls of the vessels, keeps them from closing. Okay? So that the hemorrhage is profuse if this layer is injured. The aponeurotic layer, we mentioned the large aponeurosis connecting the frontalis with the occipitalis. Okay, and we've studied even the nerve supply of the muscles, here by the temporal branch, here by the posterior auricular branch. It's a tendon of a muscle, but let me tell you something. All injuries, cuts above the galea aponeurotica, which is the aponeurosis, don't leave scars. But if the cut reached the galea aponeurotica, there will be a deep scar left after healing, because this layer is under tension because of the aponeurosis and the grasping muscles. So whenever a cut is introduced, the margins of the cut will never approximate again because it's under tension. You know what I mean now? Okay. The layer of the aponeurotic layer, we said it belongs to this muscle. Then comes the loose connective tissue, which the scalp moves on it. Actually, you can move layers of scalp on your skull through the plane of loose connective tissue. Of course, if it's loose, so it's a plane for spread of infection. So the plane of spread of infection is the loose connective tissue layer. The plane of deep scarring is beyond the galea and beyond, okay? And the profuse bleeding from the skin, okay, and connective tissue layer. The pericranium is the periosteum, simply the periosteum of the diplo of the skull, and it's called the epicranium. You can peel it off the skull, except at the sutures where it's fused there. The innervation of the scalp. See, now we're dealing with the whole scalp. Let's take the vertex of the head as a reference point. Anterior to the vertex, we have the auriculotemporal nerve here, branches. See, auriculotemporal nerve. We have supratrochlear and supraorbital nerves, right? we have the zygomaticotemporal nerve coming from the back of the zygomatic process. Okay, this is the supply anteriorly, auriculotemporal and the supratrochlear and supraorbital. Behind the level of the vertex, we will get the great auricular nerve. See, supplies part of the scalp behind the ear. We will get the lesser occipital nerve, another area in the scalp. Remember, all these are anterior primary rami. They are branches of the cervical plexus, okay? Ventral rami, excellent. Now, beyond that, this is the dorsal ramus of 2, which is the great occipital nerve. There is another nerve at the back here, the third occipital nerve, okay, which is the dorsal ramus of C3. They are dorsal rami. Now, here from this line backwards, dorsal rami of the spinal nerves that supply the scalp. But anteriorly, you have the auriculotemporal cranial nerves, and you have a couple of cervical nerves that come from the cervical plexus, the great auricular and the lesser occipital. We are repeating names now because we know them by heart so far. So there is no problem. Okay, we studied all this. The arterial supply from the superficial temporal, from the occipital, from the supratrochlear and supraorbital arteries for the scalp. Of course, the source here will be internal carotid, and here will be external carotid. The veins follow the arteries. I'm sorry about this drawing again. This is wrong. The superficial temporal artery actually in front of the vein. The same like the relation between the artery, facial artery, and facial vein. You see that? Okay, and lymphatics. Some anterior parts go to the submandibular, the rest go to occipital nodes, mastoid nodes, for example, and then eventually to the deep cervical lymph nodes. That would be it for the face and parotid. I hope you got all the benefit from these lectures. Thank you very much for watching.